Welcome to GatewayC Live, Greater Manchester. Fast facts, supporting earlier and faster cancer diagnosis.
Gynaecological cancers. Think A to G. Our specialist is Dr. Nadia Ali Ross, consultant obstetrician and gynaecologist. A. Any persistent symptoms?
Ovarian cancer can present in very vague, non-specific symptoms. But when you look at most ovarian cancers, most of them will have had some symptoms in the preceding few months before presentation. The non-specific symptoms that are commonly reported are abdominal distension, bloating, early satiety or feeling unable to eat, and indigestion is something we see quite commonly. Less common features may be non-specific pelvic pain, back pain, maybe urinary frequency. NICE and the British Gynae Cancer Society suggest that frequent symptoms happening more than 12 times per month, around half the month, may be more significant, and certainly if they've been going on for a long while. Less common symptoms could be women presenting with an actual mass or abnormal bleeding. Some ovarian cancers are hormone secreting. Weight loss and altered bowel habits can also present, but are often associated with quite advanced ovarian cancers.
B. Bleeding.
90% of women with endometrial cancer will have some form of abnormal uterine bleeding. The vast majority will be postmenopausal women. So in the postmenopausal woman with postmenopausal bleeding, I would recommend you refer them all on the 2-week wait pathway. I wouldn't particularly delay for a GP speculum and assessment if you've got prompt access to a one-stop postmenopausal clinic. NICE does recommend GPs assesses and considers a speculum before referring on, but if these women are going to be seen within a week or so, they'll have all of those tests done all at one stop by a specialist, and I think that's the most time-efficient way to do that. Any abnormal bleeding at whatever age, we need to be concerned, is there a cervical cancer? So this group requires assessment by the GP and a pelvic examination so that we can get them down the right referral pathway. If we think it's a postmenopausal bleed and the cervix is normal, they need to go to a one-stop PMV clinic. If the cervix is suspicious, they need to go to a general gynae clinic where we can biopsy the cervix at that same visit. With the younger women, what we find is there's a higher incidence of infection with postcoital bleeding, so that should be screened out in primary care.
C. CA125.
The first line when women present with these symptoms would for GPs to do a CA125 and an ultrasound scan. NICE suggests you do a CA125 first, and then if it's raised, do an ultrasound scan. And I guess that would depend on what other symptoms the women are reporting, what age they are. If you think it's a young woman with irritable bowel syndrome, that may explain the symptoms, fair enough. But a 50-year-old plus woman presenting with query irritable bowel syndrome is more worrying because they don't usually present for the first time later. So I'd have an earlier recourse to scan in that group. CA125 in itself is not a very sensitive tool. It's absolutely not diagnostic of ovarian cancer, as it can be raised in many conditions. Benign conditions such as fibroids, endometriosis, just being on a period, being pregnant can all increase this, as can smoking, any inflammatory condition affecting lungs or abdomen, and cirrhosis. So there's a multitude of benign conditions that could cause it to be raised. In early stage cancers, stage 1 ovarian cancers, only 25% have a raised CA125. And this reflects the fact that actually the higher the CA125, the more advanced the disease. And sadly, that we are picking up ovaries usually at stage 3 and 4 by the time they present.
D. Discharge.
But other worrying symptoms would be a new postmenopausal discharge, particularly if it's associated with hematuria or thrombocytosis. We should be referring these women on a 2-week wait pathway for assessment of endometrial cancer.
E. Examination.
NICE recommends pretty much all abnormal bleeding has a pelvic examination by the GP. However, I've mentioned earlier that postmenopausal bleeding I wouldn't delay referring her on a 2-week wait pathway to arrange a GP into pelvic examination. I just refer that patient straight through to a one-stop postmenopausal bleed clinic where she can get all the right tests straight away. If you have women who've reporting perimenopausal or premenopausal abnormal bleeding, you need to see and assess and think what's going on. The perimenopausal, the reason GP should assess is to make sure we're not missing a vulval or cervical cancer or any obvious infection that needs treating and managing appropriately. If you think it's a benign cause, you can see an obvious cervical polyp that doesn't look concerning, you can just refer on a routine pathway. It doesn't need to come on a cancer pathway. For younger women with premenopausal abnormal bleeding, it's worth GP assessment, swabs to make sure it's not infection, and trialling medical treatments as recommended by NICE, hormonal agents, tranexamic acid, mefenamic acid, and seeing if they settle over 3 months. If they persist, then they need gynae input, but not on the cancer pathway. Just a routine referral would be okay.
F. Family history.
Family history is really important as well. So people who have family history of BRCA 1 or 2 or Lynch syndrome are at higher risk of ovarian cancers, and we should have a higher suspicion of symptoms even if they're not happening for that long or that frequent. We should be a little bit more concerned about these vague symptoms in women, particularly over 50 years of age, but we should be thinking about screening women from 18 onwards, as there's a peak of ovarian cancers around the mid-30s and again towards 70. So just mindful of these non-specific symptoms in women.
G. Greater Manchester Referral Proforma.
The best way to send them is by the suspected cancer referral standardised proforma, where we can capture all the information and it can be sent through electronically. That's the best way to come through because it has the ability to put all the information there. We include details about BMI, clinical frailty score, which are really key when we come to treatment planning and can be quite difficult to glean without adding extra visits to this patient or telephone contacts, which are quite distressing to women once they know they've got a cancer. So if we could have that baseline data from the GP on that standardised referral, it would be really helpful as well.
Think A to G. A. Any persistent symptoms. B. Bleeding. C. CA125. D. Discharge. E. Examination. F. Family history. G. Greater Manchester Referral Proforma.
GatewayC Live, Greater Manchester. Fast facts, supporting earlier and faster cancer diagnosis.